the invitation, again to Harry for organizing this and arranging it, and for Tamir for putting it on every year. It's an honor to be here. I'm going to go quickly, but I wanted to discuss adenomyosis because I really think we have to rethink the relationship between the symptoms we've always attributed to endometriosis and the presence of adenomyosis. So just for a little background, I'll go briefly. Adenomyosis, by definition, is endometriosis glands and stroma present in the uterine musculature with adjacent smooth muscle hyperplasia and fibrosis. It can be focal or diffuse, and when patients have a hysterectomy, which is how the disease has been diagnosed for many years, it is found anywhere from 20 to 48% of the time. It was first described in 1860, but the current terminology was described in 1972, so it's relatively a modern diagnosis. One of the problems with adenomyosis is that we don't have standardization of the definition, even a histological definition. So these are three of the most common definitions of adenomyosis. The first of which is endometrial glands within the myometrium greater than one low power field from the basalis layer of the endometrium. The second is endometrial foci being deeper than 25% of the myometrial thickness. And the third is glandular extension anywhere from 1 millimeter to 3 millimeters below the endometrial layer, or 2.5 millimeters below the basalis layer. So all three of those definitions are currently being used, and typically if you'll go to your pathology department, you'll find that each pathologist within the department has their own definition of adenomyosis. At least at the Harvard hospitals, there's not one standard histological diagnostic criteria, which is a problem. So the clinical presentation of adenomyosis, by far the most common presentation is heavy uterine bleeding. 30% of these patients present with dysmenorrhea. Some present with back pain, dyspareunia that we heard about a little bit in the previous lecture, and I'm going to focus on infertility. So the question is, how do we make the diagnosis of adenomyosis? Well, the most helpful, I think, is a history. And so when you take the patient's history, you have a pretty good idea that she's going to likely be suffering from adenomyosis just by talking to her and discussing her symptoms. But the classic way prior to hysterectomy has been with the use of an MRI. And as we all know, the value of the MRI, the cost of the MRI is very expensive. So therefore, it's underutilized, which it should be. And so patients were being underdiagnosed. Now, we're going to talk about the data that we're getting from ultrasound. And most gynecologic practices do have ultrasound in the office. We're able to diagnose this disease very accurately and a lot more commonly, a lot less expensively. We can also use hysteroscopy, but again, as we talked about, the diagnosis is typically confirmed by histology, which has been a hysterectomy specimen. So MRI, what we're looking for with an MRI is a large asymmetric uterus, a thickening of the junctional zone, an increased ratio of the junctional zone to myometrial thickness, and then we look for foci of low signal intensity within the myometrium. This is an interesting picture when I got this that described the adenomyosis, and from this particular article, what's interesting is that they were measuring here the junctional zone and saying how thick it was, and this is how they made the diagnosis of adenomyosis. What they miss, which is obvious probably to everyone in the room here, is look at this deep infiltrating endometriosis that's going from the adenomyosis to outside the uterus into that rectovaginal space. Didn't even talk about it in this article. All they were talking about was this was from a radiological article, journal, looking at the thickness, missing the deep focal adenomyosis as well as the deep infiltrating endometriosis. So I think the excitement, and the reason I say now we have a problem, is now we can make this diagnosis with ultrasound just as accurately as you can with the MRI. So we're making the diagnosis of adenomyosis in these adolescent patients that you discussed this morning, I just recently found an adenomyosis in a 17-year-old by ultrasound, and now we got to figure out, and we have to rethink all these symptoms that we were attributed to endometriosis are very, very likely due to adenomyosis. And what the heck are we going to do about it? Because you can't go in there and resect adenomyosis like you can endometriosis. So this is why I say we're going to be able to make this diagnosis, but we also have a problem as to how we're going to manage it. So with the ultrasound studies, and I'll just show you an example here. This is by ultrasound, this is an MRI. So by ultrasound, it's very obvious. You can see here's the endometrial echo, and you see thick asymmetry of the thickness of the myometrium, just as you do with MRI. The ultrasound criteria, and I give a lot of credit to Caterina Isaacson from Italy, because she's done the pioneering work with the ultrasound criteria. She's looking at a junctional zone variation, what she calls the junctional zone difference of greater than 4 millimeters, which is the thickest portion of the junctional zone minus the thinnest portion of being greater than 4 millimeter. The maximum junctional zone thickness of 12 millimeter, myometrial asymmetry, myometrial cysts, striations, hockey stick of the endometrium, and reduced Doppler flow within the myometrium where there's focal adenomyosis. And the key here is that when you send a patient to the radiologist and they say there's no fibroid there, they'll say the exam was normal, the uterus was normal. But if you know the patient's symptoms, you're doing the ultrasound yourself, you know to look for these areas, you're going to find adenomyosis in the patients that have dysmenorrhea, even the young adolescent patients that have dysmenorrhea, dyspareunia, and back pain. It makes so much sense when you think about it. When you have a patient that has stage 1 endometriosis, and she's got a peritoneal lesion that Dr. Isaacson has showed you this morning, how does that cause cramping, severe cramping during menses? It probably doesn't. That patient has adenomyosis, but we didn't know to look for it. Because I promise you, now if you are aware of it and you learn how to do the ultrasound yourself, you have the patient's history, you're going to find it. So this is an excellent study by Daniel Luciano and Exos Custos. They looked at 54 women prior to a hysterectomy, looked at least 2 ultrasound features that we mentioned for adenomyosis. The diagnostic accuracy, if the patients were not treated with any type of hormonal suppression, was 90%. And if they were on hormonal suppression, it was harder to diagnose. It was only 50%. But look at this. You had a positive predictive value of 99% with the ultrasound. And so, again, this is with a biopsy-proven diagnosis based upon the ultrasound findings. So just some examples of things, and some of these are from my patients and some are from the literature. So again, if you look, here's the endometrial echo. We often find these little cysts within the myometrium in patients with dysmenorrhea. If you're doing the 3-dimensional scan yourself, you could see these cysts just below the basalis. Here's another one here. This again, if this is focal adenomyosis, so if you're doing the transvaginal ultrasound yourself, and you know that if you see the uterus going off to the right-hand side, she's retroverted, and if it's going to the left-hand side, she's anteverted. So and you most often find adenomyosis in the posterior wall. So this is a retroverted uterus, and you see this hyperechoic space with this cyst. This is focal adenomyosis. This is a patient, and here again you can see the cyst right here. This is a patient that had gone to the radiologist. They said they didn't see any fibroids. She had hypermenorrhea at the time, so they said it was normal. This is not normal. This is a patient who has adenomyosis. And in a paper that's currently in press, that's the author is Beryl Benasraf and her group, she's suggesting that a patient come in and get a thorough ultrasound for any infertility evaluation, and part of which, what she's looking for, if you could see on this 3D exam, as well as on this 2D, you'll see these cysts within the myometrium. This is a patient with infertility that has classic adenomyosis by ultrasound criteria. So it is just as good, and maybe even better, than the MRI. Hysteroscopy is part of our infertility evaluation in our practice. Office hysteroscopy is, and it's there are some excuse me, there are some findings that you'll see pitting of the endometrium toward the myometrium, which again is pathognomonic for adenomyosis. And this is a still picture, again, where you could see this pitting of the endometrium toward the myometrium in patients that have adenomyosis. Now, adenomyosis, what's its relation to fertility? That's a great question, because all our patients in the past had treatments in which they couldn't get pregnant. So they were either placed on a Mirena IUD, or they were given an endometrial ablation, or they had a hysterectomy. So is there a relationship between adenomyosis and fertility? So if you go back and look at the baboon data from 2004, they looked at 37 baboons with adenomyosis, 38 without adenomyosis based on necropsy. The odds ratio that these baboons had endometriosis was 31.5. Lifelong infertility with adenomyosis, the odds ratio was 20.6. And if they only had endometriosis without adenomyosis, the odds ratio of infertility was only 3.6. So at least in the baboon model, the adenomyosis was much more important for creating infertility than the endometriosis by itself. Take patients who have deep infiltrating endometriosis with and without adenomyosis. If they looked at their pregnancy rates, this is from Versalini 2014, if they have deep infiltrating endometriosis with adenomyosis, only 7 out of 59 of these patients conceived. If they had deep infiltrating endometriosis without endometriosis, 74 out of 172 conceived, with a reduction in pregnancy rate due to adenomyosis itself of 68%. So the adenomyosis was at least, if not more important, impact negatively on infertility than the endometriosis itself. And there's lots of studies. This is out of Japan. They looked at 413 patients undergoing in vitro fertilization and just looked at those who had asymmetrical myometriums. And if the myometrium was thicker on one wall than the other wall, then these patients had suggestions of adenomyosis. They had lower implantation rates, lower clinical pregnancy rates, and lower live birth rates. Now, I'm the first to admit that the data out there are not always consistent. This was an article that looked at, a group that looked at adenomyosis in patients undergoing in vitro fertilization, but these patients had no symptoms. They had no dysmenorrhea, they had no dyspareunia, they just happened to find it on ultrasound, and their conclusion was that the adenomyosis in this patient did not affect the implantation rate in patients with asymptomatic adenomyosis. So there are lots of studies. I'm just going to breeze through them because they're all, and I'll go through this one, which I think is probably the best. It was most comprehensive, published in Human Reproduction 2014 by Versalini's group, and again, looked at the impact of adenomyosis on in vitro fertilization outcomes. And what they found was that they had a lower implantation rate. The clinical pregnancy rate was about the same in this group between that and controls. They had a higher miscarriage rate, and they had a statistically significant lower live birth rate. So it does seem that at least with in vitro fertilization, adenomyosis adversely impacts the outcome. So again, how are we going to treat this now that we find it? The suppressive therapies and the surgical treatments all prevent fertility. And in your young adolescent patients, you're obviously not going to use anything that's going to compromise their long-term fertility. So fertility enhancing therapies include GnRH alone, ART, surgical resection, and ablative therapies. GnRH alone, again, very small amount of data on these cases as far as the impact on fertility. But however, if you do use it and you use it for up to 1 year, it did seem to help their fertility for 6 to 12 months. But after 12 months, the infertility rate was back to baseline. Now, surgical excision is what I really wanted to talk about, and I'm sorry I'm running a little late on this, but let me go through the surgical excision and what we do here. So with surgical excision, this was described in Japan, and you go in and you just try to find the plane between the adenomyosis and what appears to be normal myometrium. You resect that out, and as those of you who've been in this position where you thought you were going to get a fibroid and you find adenomyosis, you know how difficult this can be. And you resect out as much of the adenomyotic tissue as you can, and then you just repair it. And this is one of our cases that we were doing. I'll fast forward it, but we've cut into it. This is all adenomyosis in the posterior wall. We're using just a bipolar spatula to cut it out. And I'll see if I can advance it for you. And it's just piecemealing it out because you can see normal myometrium here. All this is adenomyosis, and we just cut it out a piece at a time until we get to what we think is normal myometrium. And then just sew it up like you would a myomectomy in multiple layers. Usually it's a 3 or 4 layer closure. So it doesn't bleed a lot, which makes sense because the fibrotic tissue is not hypervascular. It's just a difficult, tedious surgery because you're trying to get out all that tissue that doesn't have a good pseudocapsule around it. So if you look at who will benefit from this uterus-sparing surgery in subfertility, this is a study by Kishi who looked at 102 women who underwent that type of surgery on their uterus. And again, in patients who were under 39 years old, they had a 41.3% pregnancy rate. If they were over 40 years old, they only had a 3.7% pregnancy rate. So for them, it was most important that the patients were younger when they had this surgery. What they also found was that it was a worse prognosis if the adenomyosis was in the posterior wall, and a worse prognosis if they had coexisting endometriosis. Grambesis looked at the operative treatment for adenomyosis, 9 studies, 469 patients, and again, he looked at whether or not they had complete excision or incomplete excision, and the pregnancy rates were very similar, which were actually fairly high. 60% pregnancy rate with complete excision, 47% with incomplete excision. Other ways to treat adenomyosis if you don't want to, if you don't feel that you have the technical expertise to do that resection, you can try to burn it with monopolar or bipolar energy. Typically is not recommended for patients who want future fertility. MR-guided focus ultrasound has been used, but just all we have are case reports as to whether or not it works. And so the bottom line in summary is that I do think that adenomyosis clearly affects fertility. You've heard from Dr. Fasliabas this morning that we see a decrease in expression of progesterone receptors. We see dysregulation of various genes. We know we have endometrial inflammation, and we have various alterations in some key cytokines. So I think I throw out infertility there because the topic was not on the list to discuss today, and I think it's important. But I think our biggest question for all of us in the future is, what's really the impact of adenomyosis now that we can diagnose it by ultrasound versus the impact of endometriosis that we can easily see by laparoscopy and we can resect? And we don't have that answer. And I got a feeling it's much, much larger than we currently appreciated. I think some research questions, we need to characterize the adenomyosis environment. We need to understand what are the cytokines present, what are the cells responsible for producing these cytokines. We need to understand the importance of smooth muscle, and we certainly need to increase the awareness and understand the true prevalence of the disease. With that, I will stop. Thank you very much.